let me start by introducing myself before I introduce the session. So, my name is Dr. Hassan Nawaz Tahir. I was in AQ for quite a while. Initially, I did MBBS, then I did my residency in community medicine, public health, preventive medicine, whatever you want to call it. And from Aachen University, I did the residency. And then I worked as a senior instructor in Aachen University, and then I left about 3 years ago. Since 3 years, I've been assistant professor in College of Medicine, Dowadmi in Chakra University. So I have been working over the years in technology-related grants, technology-related projects. Even in Aachen University, I was involved in a lot of digital technology solution developments. I have been involved in entrepreneurship for quite a while now. It has been some around 8 years. We have developed various different tools and tech. Currently, within Saudi Arabia, we have something called as the Vision 2030 that you can like see here in the middle. The Vision 2030 has a lot of digitization and artificial intelligence built into it. That's the vision is to digitize the whole country. That's just one part of the overall vision. It's a very large vision. The primary core of this is to improve the economy and wean off Saudi Arabia from oil-based economy to a maybe a service-oriented economy. There are some key players when it comes to. So I basically am a teacher here in Chakra University. There are some key players when it comes to technology innovation in Saudi Arabia. One of them is this RDIA, Research Development and Innovation Authority, and the other one is the NIH, Saudi NIH. And then obviously me being a public health person, so I engage with the Public Health Authority. The Public Health Authority has created something called as a Public Health Academy. All of you can go and check out this Public Health Academy of Saudi Arabia. It has courses which are absolutely free. If you do those courses, you get free certification. So in Arabic, you call Public Health Academy as Waqaya. So the Waqaya Academy, Waqaya is basically Public Health Authority, and within that, you have the Public Health Academy. And this is just a brief of the kind of entrepreneurial work that I've been doing. So I don't want to go into the details of that. Um, so, what is the session about today? So, we have around 3 hours, and I want to keep this as interactive as I possibly can. So, some of the key outcomes. What do we want at the end of this session? What do you want you guys to know at the end of this session? Well, you should be able to identify biomedical devices, classify them based on the risk, based on the function. We will also go through some WHO classification of digital technology. Apart from that, from a health manager's perspective, everything that we'll do today will be from a hospital manager's perspective. This will not be from a clinician perspective. This will not be from a public health or a researcher perspective. This will be from a hospital manager perspective. The whole presentation has been built in that format. We will look at what is the total cost of ownership of any equipment that is procured and how that decision follows. We will do a group work around this procurement process for technology that we are procuring for the hospital. Apart from that, we will look at what are the decision frameworks during equipment failure scenarios. So we will run ourselves through a scenario where equipment fails in the hospital, a technology equipment fails, and then what do we do? So what are the options that we have? So we will run it through. I have not been a hospital administrator myself, so I'm pretty sure that the cohort here that is listening to this session knows far more about hospital administration than I do. My core area is health technology, so that's where I come in, that's where I guide. Being part of entrepreneurial ventures over the years, what I've learned is that new technologies have to have an ROI. So that's what we will cover today. ROI is return on investment. And then also there has to be interoperability. How do we make sure that our technology can be integrated within the overall health system where we are operating? And then, so what are the regulatory frameworks as well? We will not go into like what is HIPAA compliance or what is say electronic medical records require some compliance measures. So we'll not go into that. What we will do is we'll just focus on, from a manager's perspective, what do we do when we have technology, and how do we manage it. Okay, so with that being said, let's start with a brief intro of digital health, and then we go through the different hands-on workshop that I've built into this. And then the teaching material we have shared with you. At the end of the day, you guys will be creating something called as a pitch, innovator pitch for the new technology that you will deploy into your hospital. At the same time, before that, we will run a crisis simulation. So we will go through a crisis and we will learn how to solve a tech crisis. We will also go through something called as the total cost of operation. So, what is the total cost of operation of any technology that we deploy within the hospital sector? Okay, so that's like the crux of what we'll cover today. We have around 3 hours, and hopefully, we would be able to cover all of this. Okay, with that being said, this is just something that I want anyone to answer here. So, when you guys look at this picture, what do you see? So if I ask you guys, okay, you are a hospital manager, um, you are to build something like this for your hospital. You live in a low income country or a low middle income country like Pakistan. So where would you spend the most money in this ICU? In this ICU, where would you spend the most money? So all of you are correct. This was just a icebreaker session. This is like to get you into like, okay, if you're running a hospital, what can happen? Okay. So if I ask you, okay, this is the hospital, you have built a world-class hospital, which equipment breaks down the most? In your opinion, which will break down the most? Which thing will break down the most? Okay, so basically, in essence, there will be breakdown of things, and all of you agree with that, that there will be breakdown. Okay, so if there is breakdown of those things, who's responsible? And it's 2 a.m. at night in the hospital. Very nice. And like everything in social science, you and I, we all know that there is no specific one answer. And we also know that there is no wrong answer. At times, responsibility, the crux of the responsibility lies with the management. And as hospital manager, you are the ones who are dealing with this. And things go wrong all the time. So if I ask you, so what would be the solution in this case? Like as a manager, you have to predict that things can go wrong. So what would be that solution? If I ask you one word, what is the one word that you can deploy that would be solution for a lot of things that can go wrong? Very nice. Redundancies. You create redundancy in every process. Because if there is a redundancy, the ventilator goes out, you have another ventilator. If the infusion pump goes out, you have another infusion pump. Having redundancy, but that's a luxury. You cannot always have redundancy because of the cost of the things that you have to pay. Okay, so let's move on. So what's the when I say health technology, what comes to your mind? What do you guys think? What is health technology? Is it your phone? Is it the ultrasound machine? Is it the electronic medical record? When we are saying technology, technology can even mean drugs. Technology can even mean devices. Technology can even mean procedures. And obviously, digital health is part of that. And managers have to like basically control all of them. Generally, the term that is approved by WHO is that health technology refers to tools, systems, devices, medicines, digital solutions which are used to prevent, diagnose, treat, monitor diseases, as well as to improve the overall healthcare delivery. It includes from medical equipment such as MRI, ventilators, infusion pumps, to pharmaceuticals, vaccines, lab diagnostic equipment, surgical instrument, information systems like EMRs, telemedicine platform like decision support systems like artificial intelligence algorithms, and all of that. And when we talk about innovations, the key innovation right now, the buzzword is artificial intelligence. And we know that very rapidly it is taking over almost everything across the whole social spectrum of society, not just healthcare. Healthcare is definitely affected by it. Okay. And then obviously we have hardware. A lot of development has been happening in the hardware. So we have new sensor technology, we have new wearable devices, we have a huge introduction of robotics within healthcare now across the world, not just in high income countries, not just in Western or Middle Eastern countries. We have, even in Pakistan, we have robotics across the board being deployed. Now, and then obviously remote patient monitoring systems are there. And at the end of the day, the core is that all of these help in decision making, and by that, all of them help in patient safety, increasing the efficiency, increasing, reducing the cost of care. At the end of the day, technology has to reduce the cost of care, even though at the starting point, there might be a initial cost that is incurred because of the technology, but overall, it reduces the cost of care. And obviously, beyond the physical devices, any maintenance system that you have, any regulatory compliance that you have, that all falls under the technology that you're using. For example, you're using some sort of cybersecurity to protect your healthcare data, or maybe you're using some form of simulation for training your, say, your physicians or your nurses, or maybe you're using some form of cost evaluation tool which uses some form of artificial intelligence like a decision tree. So that also falls under health technology. And effective management of the health technology basically is that you end up with a safe hospital, a reliable service, a cost effective service, and obviously the core is that it should be aligned with the patient needs. So that's like a crux of what it means when we talk about healthcare technology. Just to give a brief into like where we are right now. So we are basically Aachen University is based around multiple countries, but primarily a lot of you guys are based out of Pakistan. So when we look at low and middle income countries, that's the criteria where Pakistan falls, which means that on an average, the GNI, the gross national income per capita per person, is somewhere around 1,000 to 4,000 dollars in Pakistan. And obviously, in high income countries, that goes down to around $12,000 dollars or more. GDP is different, but somewhere around GNI is this. So you can say, but people make somewhere around 40,000, $50,000 in the US. How can it be so low? Because, well, it's divided across people who are also falling in the dependency ratio. Dependency ratio are people, children less than 15 years of age, and adults above 60 years of age. So that's why the GNI is this. So in Pakistan people make somewhere around $1,000 to $4,000, which is gross national income per capita. And this we are talking about yearly income. And then we have somewhere around low income countries, a lot of African countries, sub-Saharan countries fall into that criteria. Um, and when we talk about countries which belong to the LMIC, because we know that there is less amount of income being made, obviously then less amount of money is being spent in healthcare. So then you end up with some health system challenges. And the health system challenges start with the human resource. At times there is no human resource. Even if there is human resource, then the human resource is not trained properly. Even if the human resource is trained properly, the human resource is not allocated to the right place. I'll give you an example. An example of that is that WHO says that there should be 4 nurses to every 1 doctor. In Pakistan, the scenario is opposite. There are 4 doctors to 1 nurses. Why? Because there is no money being made when you are a nurse. So a lot of people opt for becoming healthcare providers, but everyone wants to be a doctor. But the thing is that the system requires more nurses. But that's not even the problem. The problem is all the nurses themselves are then in the urban areas. So there is a surplus of nurses in the urban areas, but there is a depletion of healthcare providers and nurses in the rural areas. So as you can see here, within human resource, right? So the loss of the human resource is like the first thing. But even then, when you have the human resource, it's either not trained properly or either the allocation of the human resource is not correct. The other problem is health financing. For example, majority of the people in low income country and lower middle income country have to do out of pocket payment. Why? Because the government does not have the money. At the same time, the insurance mechanisms are not that strong in the private sector. So people end up paying out of pocket. And because of that, they end up with something called as catastrophic health cost. Catastrophic health cost is that people lose a certain percentage of their overall savings in healthcare. So there is a whole mathematics behind it. You guys can read up on it. What is catastrophic health cost? Other than that, budget and resource allocation is another big issue. For example, if the government has certain money, they want to put that money, more money into tertiary care facilities. Even though we know for a fact that if we put more money in the primary healthcare sector, the return on investment, or you can say that the cost effectiveness, there are two things: cost effectiveness and cost benefit. Cost effectiveness is that if I say spend X amount of dollars, what is the improvement in the health outcome that I get? That's the cost effectiveness. And the cost benefit is that if I say spend X amount of dollars as a healthcare manager, then what is the financial benefit that comes out of it? So, how much money do we make? That could even be seen as a profit, or that could even be seen as cost reduction overall for the government if the government is spending. So a lot of the investment is done in the tertiary care sector. So it's not done in the primary care sector. Why? Because a big hospital looks amazing on news and it's like something that you can showcase on your portfolio. But if you build like say 30 PHC centers, they don't look that great. So that's also like a political mentality, and that also affects health financing. Other than that, within the governance sector, what happens in low income countries and low income countries, a lot of the healthcare governance is centralized. So because it is centralized, so it has its own issues. The issues are that there is a lot of corruption because when you have power, there is a saying that power corrupts, and then absolute power corrupts absolutely. So if you have a lot of centralization, then you have a lot of power. If you have a lot of power, then there is a lot of corruption. And a solution to that is, according to WHO, that you can use digital technology here. And digital technology can be used for what? For building transparency. First, you bring transparency, and from transparency, you get accountability. What is a simple way of bringing transparency? You develop, say, a public dashboard of the resources that were allocated to the health system. And then the same public dashboard showcases how many people got the treatment, what was the improvement in the health outcome. So that's like a public ledger, a public dashboard. Public dashboard is nothing more than a website which basically has some statistics and some data visualization that is available to everyone in the society around the globe, and everyone can use it and audit. So it's like a public audit. So transparency leads to accountability, and so digital technology is here as well. Another issue within the health system that we see is service delivery. There is a rural urban divide. No one wants to work in the rural area. Everyone wants to work in the urban area. Distribution of health professionals again is because of that. And then there is a whole host of system that is just unregistered. So you have rural healthcare providers. So a nurse might become a doctor in a rural area because there is no doctor available. Similarly, you might have people who are not even nurses. You might have people like, for example, someone who never went to any sort of training in healthcare. They maybe worked in a hospital for a few years and then they started to have their own clinic. So that's like a very common practice in low income countries. And then obviously, essential drugs. WHO has given a list of essential drugs for every country. Those essential drugs should be developed within the country to reduce the cost of drug delivery within that country. So that again is not possible with every low income country and every low and middle income country. This I just wanted to give as an introduction of the issues that we face in the low and low middle income countries. You guys are already in your semester 3. I know all of you are aware of all of these things. That's why I don't want to spend a lot of time here. I just want to move on. These are the building blocks of health system, the six building blocks. I will not go into the details of that. Pakistan has a segmented health system. Pakistan has sort of like a three-tier health system: primary care, secondary care, tertiary care. And then obviously we have the big boys also running few things. Those are separate to the overall public health system. Even though previously in Pakistan, the public health system was catering to only 30%, but now that has improved. And now public health system caters to somewhere around 45 to somewhere around 55% of the patients. And then we have the private health sector. The private sector makes up a huge amount of the overall health system in Pakistan. This is basically like a picture I got from Sania Nishtar's book. She was previously a health minister, and then she's currently, I think, DG of vaccines in Gavi. So, with that being said, there are some digital health domains and terminologies that you guys should know. Digital health is like an umbrella term. Okay, within that umbrella term, there is telemedicine. There are wearable devices. Telemedicine just means that we have one device and another device. One device is with the patient, another device is with the doctor, and there is a connection. Now, the patient device can be a phone. The patient device can even be a clinic, and the clinic has a laptop, and the patient is sitting in the clinic with the laptop, and then the specialist is in some other city. So something like that. That can even be the case. Your phone can also be that. So telemedicine is like now in work for like the past 30 years, and we perfected telemedicine during COVID. And now, like almost everyone has been through some sort of telemedicine practice across the globe, even in low income country. By the way, more in low income countries. We are now seeing the use of augmented and virtual reality, especially in education and training, especially in high income countries. In Saudi Arabia, I see a lot of use of augmented reality, a lot of use of simulation patient models, because of the insurance mechanism in the country. A lot of the patients, the doctors or the residents don't get to see patients directly as is possible in low income countries. So what they do is the hospitals have deployed a lot of augmented reality simulators that really help the patients and the doctors in training. Also, we are seeing artificial intelligence across all the building blocks of the health system. WHO says when you have to look at digital interventions, you need to classify them. There is a classification of digital interventions. Some are for clients. Clients means basically for patients, and some are for healthcare providers. So there is a classification for patients, there is a classification for healthcare providers, there is a classification for managers, for health system managers and resource managers, and then there is a classification for data services. Okay. So this is just a infographic that basically shows that there are some health system challenges, and this is coming from the monitoring and evaluation of digital health. This is a document of WHO. So they say whenever there is a health system challenge, you can bring in a digital health intervention, and from that digital health intervention, you can then solve a problem in a specific system category in a specific building block. So for example, if you have insufficient supply of commodities, you can then deploy inventory system. You can then deploy a LMIS, Logistic Management Information System, and that would solve the problem. Similarly, healthcare providers, if they're not adhering to clinical guideline, well, you can then give them feedback. Feedback can be given digitally. You can also provide them with a checklist or a protocol. That protocol can be digitized, and then that turns into a decision support system. Okay. Similarly, lack of access to information. If patients don't have or people don't have access to information, then you can provide that through LMIS, HMIS. HMIS is Health Management Information System. You can also do that through the electronic records and also through public registries, vital statistics, and all that. And obviously, if patients are like not being not followed up in the clinic, then you can develop, say, apps that can help in client communication systems. For example, just a reminder app for the hospital can be created very easily, very low cost with AI. It literally takes like 2 minutes to build it. This is a classification of um, the WHO classification of digital technology for healthcare providers. And this one is for healthcare managers. For healthcare managers, they say, you need to have some digital technology resources for human resource, some for supply chain management, some for healthcare financing. I'm not going to the details of this, some for civil registry, some for public health notification. Like we applied something like this in COVID in Pakistan, where we had a central notification and a central registry for COVID. And then obviously some for equipment and asset management, and some for facility management. So again, I don't want to go into the details of this classification. This is a very famous classification. You can just Google WHO Digital Health Intervention Classification. And for healthcare providers, there are like from health records to decision support system to telemedicine to referral to somewhere around prescription. How to prescribe medicine so that there is no wrong prescription, how to track the medicines so that we can reduce the chances of counterfeit medicines, something like that. So, with that being said, this is again something I want everyone to see. This is called as the theory of diffusion of innovation. So, diffusion of innovation theory, which basically says that if we have a society, in a society, 50% of the people are pro innovation and 50% of the people are, say, you can say they are latecomers to the game. Okay, so 2.5% of the people are actually innovators, they actually build the solutions. And then you have some early adopters in the society. Early adopters are like somewhere around 13.5% of the people. So if you combine both of these, it's around 15% of the society is people who develop the solution and people who are early adopters. Early adopters are people like on a very cold day, they are standing outside of the Apple store to buy the new iPhone. These are like the early adopters. And then there's a early majority. These are the people who only buy something when they see one of their family member or someone they know using a technology. And these are the people who are willing to adopt, but they only adopt the technology when they see someone else using it, someone that they know. And then you have the late majority. These are the people who only use the technology when they have the fear of missing out. Fear of missing out, FMO. When that happens, only then they use the technology. This applies to doctors, this applies to healthcare managers, this applies to nurses, this even applies to our patients. And then there are 16% of the people in a society who are laggards. Laggards are people, they will never take up a technology unless that's the only option left. For example, how do you make sure that everyone in the society uses the technology? Well, you apply certain rules and regulation. And because certain rules and regulations are applied, for example, there will be some hospital managers that will just not take up digitization. But when there is a rule by the government that it has to be done, then they have to follow. So they are in the laggard category. What people should understand is that even though this represents 50% of the population, this up till early majority, and this other part, this represents somewhere around the other 50% of the population, this part takes somewhere around 80% of the time. So when a technology is being deployed, as you will see, if I'm pretty sure a lot of you are doctors, and if I ask you to raise your hand, and if I say, will artificial intelligence algorithm take up your job? 90% of you will raise up your hand and say, no, it will not. No tech can ever replace me. Like the farmers in the 16th century said, no, no technology can, no industry can ever replace us. So something like that. Or someone riding a horse would say, I would never leave my horse. I would travel from Karachi to Hyderabad on a horse. You can travel from Karachi to Hyderabad on a horse, but you guys know the answer, right? So that would just now be something that you do for fun. So I hope we don't end up becoming the things that people used to do for fun. So, so people use what people forget, especially in the healthcare sector, is that 80% of the time is spent in achieving this. Okay, early majority, and AI is here now. Okay, AI is here, and only 20% of the time takes to get to the other 50%. This is very fast. This is downhill. This was the uphill battle. This is downhill, and this is the very fast downhill, a very short downhill. So people might say, okay, maybe 50% of the healthcare providers are using AI for their patient care and anything, but it will never replace us. You're right, 50% are using it, only 50%. But you see, 80% of the journey is complete. This has been seen with previous technologies as well. One of the technology for which this was seen was information communication technology, ICT technology, which was, you can say, mobile phones, early mobile phones, and then the disruptiveness that came with the smartphones. So I don't want to spend more time here. This is just, I wanted to share this. WHO has a global strategy on digital health between 2020 to 2025, and then they have extended this to now 2030, the same strategy. And basically, the strategy says that whatever that you build, whatever digital technology that you build, focus on patients, focus on sustainability. So it should be appropriate, accessible, affordable, all the WHO terms, okay? And then you should be able to take care of epidemics, pandemics, and you should obviously focus on developing infrastructure, especially enable countries to use their own health data, and eventually support in SDGs. That's the crux of it. Okay. And WHO says when you are to deploy any digital technology in any health system, then you need to have a three-tier approach. The three-tier approach should be that you need to engage the policymakers, you need to engage the practitioners, and then you need to engage the population itself. The policymakers, the decision makers at the local and regional level, at the national level, and even at the international level, and then the practitioners, basically people who are going to be treating, so nurses, doctors, physiotherapists, lab technicians, and the whole group. Okay. And then patients, not just the people who get sick, but also the healthcare providers, also their like family and people who are their caregivers. Okay. Now, now we actually start our session for today. This was just the crux, the introduction of what I want to do up till here, just to build up the case for digital technology. Now, digital biomedical devices have a hierarchy. Okay, some when and now I'm focused primarily on biomedical devices that we are going to deploy in the hospital. I am not a biomedical expert, so I cannot go into the depth of biomedical devices, but I can just give you a crux of what it is. So, in the hospital, we have some low tech devices, we have some medium tech devices, and then we have some high tech devices. The low tech devices are like beds, so wheelchairs. The medium tech devices are infusion pumps, monitors, and then there are some high tech devices, which are MRI, which are ventilators, which are now robots, and when we are dealing with low-tech devices, the focus is on inventory. How many of them do we have? How many do we need to purchase? And we know that there is like less amount of loss when it comes to these. In medium tech devices, the focus is on calibration. Are the devices ready? Are the devices accurate? Is the measurement correct? Are they valid? Are they reliable? Are they fair? Um, means is the cost something that the patient can actually afford? So those are the questions that we ask. And then when it comes to high tech devices, the questions are completely different. The questions are focused on the contract. For example, okay, I have an MRI machine. If I have to replenish, say, the magnet, what is the cost of that? Can the magnet only be replaced by the same company from which I bought this machine, or can I buy it from, say, an open source or say any vendor? Because that dramatically changes the cost. Similarly, ventilators. Where do I get the replenishable items for the ventilators? From the same company from where I bought the ventilator, or can I get it from anywhere? Similarly, for robotics, same thing. And that brings us to the cost. As a hospital administrator, everything is cost. Everything is real, everything is dollar, everything is rupiah, paisa. Okay. And then, so there is this WHO classification, which is focused on technology for health system managers, okay, and healthcare providers. And then we have this classification, which is focused on the biomedical device hierarchy, low tech, medium tech, and high tech. And then we have device classification based on risk. This is actually, as a healthcare provider, as a hospital administrator, this is like your number one priority. You have to reduce the risk. So there are some devices which are low risk. There are some devices which are moderate risk, and then there are some devices which are high risk. Low risk devices like a stethoscope, which, like, think of devices that are like basic tracking devices. So, like a weighing machine, a measuring tape. You can also look at other things like thermometer, low tech, low risk. Okay. Then you have some medium tech devices. So, medium tech, medium risk. You can think of ultrasound machines. Okay. You can think of X-ray machines. You can think of lab equipment, centrifuges, you can separators, you can think of say some physiotherapy machines, okay, and then you have some high tech, high risk machines, ventilators, some backup generators, some compliance critical machines, like for example, not just the ventilators, but there are also other devices which can be like different for different specialities. For example, a cath lab, a cardio angiopathy machine. Even like the criticality is very high. And in this, the most important thing is the service level agreement. So if you procure something from anyone, what was the agreement? What was the formal contract between the hospital and the equipment provider? This is like, it has various layers to it, but as a healthcare manager, you need to know what are the high risk equipment, and then within those high risk equipment, how do you calculate the cost for your hospital, especially if you are working in a public sector hospital where you know that there might be a cost reduction every now and then, even in a private sector hospital, where you know that you can, even though there will be replenishing of the items, or there would be a compliance mechanism, but still there is a cost to everything, and you need to, like, balance the budget. And then why classification matters, like I said, insurance reimbursement. A lot of the equipment in the hospital are also insured. At the same time, a lot of the patients that come to the private sector are also insurance-based patients. And say if a equipment, say you are treating a patient, if you're treating the patient and the patient is coming through an insurance program, or even if the patient is like giving out-of-pocket payment, you have a equipment and X equipment, and then that X equipment, it might, it has a like 5 year life. So you will budget that on the patient, because how will you replace the equipment after 5 years if you do not budget it? So those are some of the things that you need to think about. So insurance reimbursement, also who's the staff who's going to run that equipment, also what are the regulatory inspections. So even though you might have equipment, even though the life might be 5 years, but what if it is not compliance ready after 3 years? After 3 years the equipment stops working or stops being compliant. So if you are in a very compliance heavy environment, then you cannot use that equipment. So then you have to think about what we have to do. Also, you must understand that these like high risk equipments are the ones that are targeted the most by the accreditation bodies. So say you're going for JCIE accreditation or national accreditation of any sort that you have in your country. So your accreditation bodies will target these devices. These are where, like, the compliance, they are compliance heavy devices. Okay. So this brings us to something that we will do as a group now. As a group, we have somewhere around, let's say, 16 students. So I think somewhere around, say, we divide the group into three groups. We divide our group into three groups, and we like create breakout rooms. And in those breakout rooms, what we'll do is we'll go in the breakout rooms and we'll calculate something called as the TCO and the procurement. We'll cover what this is in just the upcoming slide. The objective of this workshop is, and then we will work on this for somewhere around 30 to 40 minutes, because now we are somewhere out at 1 hour is past. We are reaching somewhere around 3 p.m. I hope you guys don't need a break just before we go into this workshop, or you guys can take a break during the, we will have some group activity in which you guys can, have some time out as you're working within the group. Okay. So right now, what I'm going to do is, as hospital administrators, I will make you guys make some procurement decisions, like a manager, like an administrator, not as a clinician. Okay. So we'll go into it. So at this point, you have to think like an administrator. Patient care is important, but uh, there is something which is called TCO. TCO is what? The total cost of ownership. The ownership is by whom? The ownership is by the hospital. Okay. So TCO is basically it is amounts to what? The acquisition cost. So what was the initial cost of buying an equipment? Then the annual operating cost. So how much money do you have to spend to keep it running? And then for how many years we have to keep the thing running, the equipment running, and then the disposal cost. So if we have to let go of something, what is the cost incurred in that? And there are some other costs, for example, maintenance costs. So, for example, consumables. For example, say you're using a probe, you're using a reagent, you're using some tubes. Generally, these are like the things that are used in the hospital. And then what is the power consumption? So, especially in a LMIC country, equipment comes later, power comes first. So what would be the power consumption, and how, what would be the cost of that, and how will you bear the cost of that? And then staff training, and then insurance. So what kind of a staff will you need for this, and what kind of insurance mechanism will be needed for this, for the hospital itself, and for like when it comes to patients. Okay. And one thing you need to understand is like, what is the manager's secret elixir? What is the manager's mantra? What is the manager's jadoo? Well, the thing is, the cheapest machine is often the most expensive. This is what happens most of the time in hospitals. And now we'll discover it as we go through the workshop, as we go through the group activity. Okay. Also, this is something that we should go first before we go through the activity, uh, which is basically that every equipment has a life cycle, and there are stages to that life cycle. There are 5 stages. For example, number one is specification. We decide that we have to buy the equipment in the hospital. That decision, that specification is done at the clinical level. The doctor comes up to the manager, the nurse comes up to the manager, the lab staff comes up to the manager, and they say, we need this. That's a clinical decision. It's based on the needs. We need this for the hospital. Then comes in the procurement. Procurement is, where do we buy this from? Who do we buy this from? When do we buy this from? And in this, the most important thing is the purchase. What's the cost of this thing? And then, okay, if there are 3 vendors, we negotiate. Where can we get the best deal for the hospital? Then the next thing in the equipment life cycle. So first we jump from specification to procurement. From procurement, we jump to installation. Okay, now we are installing it in the hospital. Okay, what is the existing infrastructure? Do we need to build new infrastructure? For example, I have a new MRI machine. Do I really need to build like a new building for it? Do I need to lay down new power lines for it? Do I need to, like, for example, I have a new technology that requires Wi-Fi across the hospital. Do I need to lay a Wi-Fi network across the hospital? Is that the case? Similarly, readiness. When will it be ready? Is my hospital ready right now, or will I make my hospital ready later on? All these things in the equipment life cycle, they go into your cost. The next thing, operation. Okay, I get the MRI machine, I get the ultrasound machine, I get the new cutting edge lab equipment. What's the operational cost? So, like, what's the maintenance like? What's the cost like? Like, what is the regular cost of operating this? Or cost of operation depends on the human resource. Do I need a special person to run this, or can anyone run this? Similarly, like if I buy the things and something breaks down, how do I get it fixed? What would be the electricity cost of this? So stuff like that. And then once 5 year time period or 10-year time period or 25-year time period of that equipment is over, then if I'm decommissioning it, can I sell it in the market? If I sell it in the market, how much loss will I incur? If I sell it in the market, can I make more money out of it? Is this thing something that can never be sold? Is this disposable, or is this something that can be resold? What is the cost of this thing? If I have to say, I cannot sell it, so then like if I have to continue using it, then what's the cost of refurbishing something like that? So these are like the equipment life cycle decisions that a manager has to make. So the most important decision for a manager is the total cost of ownership, the TCO, and then with that, okay, what's the life cycle? And then so this brings us to our group activity. We can have these group activity for like 20 minutes. In this group activity, what we'll do is we will first we'll divide you guys into like five groups. This is what we'll do. We'll divide into three groups, okay? Each group will have 5 plus 5 plus 5. Okay, 5 x 3. So somewhere around 15 people. So divide into three groups. Okay, we will create a breakout room. We will divide you guys. Okay, we will give you something called as the TCO worksheet, the total cost worksheet. Okay, and then what you will do is that you will play the role of the hospital purchase committee. The five people will be the hospital purchase committee, and in that you have to like purchase a hospital equipment, healthcare technology, uh, that you will deploy in your hospital. You have to calculate the cost for year zero, okay, which means that the purchasing cost and then the training cost. So when you purchase the equipment and then you train your staff on that equipment, what was the cost of that? So purchasing cost for year zero, and then you have to calculate the cost from year one to year five. So that's the AMC. AMC is what? AMC is this, the annual maintenance contract. What is the annual maintenance cost? And then you will add all the 5 year cost for each machine, and then you will discuss which one is better, okay, and why. So let me show you what that looks like. I think the that has been shared on your LMS. Let me just stop sharing this and let me just share the document. This is the worksheet. The worksheet has been shared with you guys. I hope all of you can see it in your LMS. Let me just share it here so that I can run it with you guys. Okay. So basically, this is the worksheet. What is this? This is basically the total cost of operation worksheet. What you will do is you will basically look. We will two groups will work on machine A and one group will work on machine B. Okay, so we will divide group A, group B, group C. Group A and B will work on machine A separately. Group A will work on machine A separately. Group B will work on machine B separately. So what you will do is first, we have given you this pricing. Okay, so this is the purchasing cost of machine A. This is what is the scenario? You are in a hospital. You are buying a high-end ultrasound machine for the radiology department. There are two options. You have to calculate the 5 year cost. You have to calculate the initial 1 year cost. They are saying work in the group for 45 minutes, but no, you only have 20 minutes. Okay. After 20 minutes, we'll discuss. So right now it's somewhere around 4, I think it's somewhere around, what time is in Pakistan? 3 p.m. So it's 3 p.m. At 3:20, we will come back and discuss. Okay. So what you guys have to do is that you have to go through the specification. So what's the cost? of individual things in this machine, and then what is the like the purchasing price. So the purchasing price is right here. So you have to cost it for, you have to do the costing for year zero. What was the purchasing price? What was the one-time training? So the training price is also here, the training cost. And then you have to go and then you have to calculate the annual cost. The annual cost will include the AMC. The AMC is given here, annual maintenance cost, annual maintenance contract, and then you have to then cost keep into the consumables, the power, and the insurance. So everything is given here: the consumables, the power, and the insurance. As you calculate all of this, then for all the years, you have to calculate all of these for how many years from year one to year five. Then that brings you. So also there is some additional cost. Additional cost is what? Software upgrade. Every company does that. If you buy any, procure any equipment, even iPhone does that to you guys at times. So the additional cost is what? 4,000 for machine A, and for machine B, it is included in the AMC, which is the annual management cost or the annual management contract. Okay. With that being said, you calculate it for every year: 0 year, 1 year, 2 year, 3 year, five, and then you will calculate the total 5 year cost as a group. And then as a group, you will analyze which machine is better, uh, by how much, and why is machine B cheaper for the 5 years. So you guys have to calculate for all three groups. So initially I said machine A, machine B. No, all three groups have to do calculation for both machine A and for machine B. Okay. And then once you're done with this, in the group, you then have to discuss. And then I will jump into the one group, then the second group, then the third group. I will randomly make those five groups, and then we will see how the groups happen. Sometimes with machine B, you will have the option of running it for 2 extra years. So you can even add that into your overall cost. So for machine A, it will just be a 5 year cost, but for machine B, for both machines, you will calculate 7 year cost. But you will say, you know what is the 7 year cost for this? What is the 7 year cost for that? Stuff like that. And then obviously you have to take into account what is the vendor reputation for machine A, machine B. These are some additional considerations. This you just need to keep at the back of your mind. Okay, this is helpful for your discussion. That's why these things are given here. And then at the end, as the hospital committee, you will make a decision. All three groups will separately make a decision, either for machine A or for machine B. We leave it up to the groups, and then you will share your decision in the group. You will come back in the group, and then you will share your decision. Okay, so this is just like the group activity. This is a template that you can use. It's just the same thing. Okay, basically, this is where the thing ends. The step six is where it ends. And the below is a worksheet, but you can use the above worksheet as well. With that being said, let me um, assign you guys automatically into the group. I will not assign the co-host into the groups. I will create three groups, and everyone who's not a host or a co-host will automatically be assigned into a breakout room. Okay. We are just doing this for the sake of time. So we have now created the breakout rooms. Okay. Three breakout rooms. We have now opened all the rooms. All of you, please join your rooms. Okay, so I hope all of you had a great time with the group activity. I hope it was not very tough to handle. Um, but I think costing is like the one thing that every healthcare manager has to learn at the start, in the middle, or at the end, but you have to go through that. So, so the scenario was that your hospital needs a high-end ultrasound machine for the radiology department. You had two options, a machine A and machine B. You had to calculate the 5 year total cost and recommend which machine to buy. We had three groups: group one, group two, and group three. Okay. Thank you. All of you did a great job. Okay. Um, Let me just share this. So this was the scenario, and these are the answers. Basically, if you look at it, So machine B is 17,000, sorry. Machine B is somewhere around 17,000 less than machine A overall. Because machine B is like comes down to 95,000, machine A comes down to 112,000. And on top of that, machine B has a longer life. So if you look at it, you get 2 extra free years. So that's also something not free, but like you don't have to buy a new machine because the procurement at year zero is very high. This is the highest cost of the whole years. So you can delay this procurement by say 2 years. So that's also something that is you need to think about. This is the reason for doing this exercise is that as a hospital manager, as a healthcare manager, you will come across situations where you will see technologies and you will see, oh, they're both the same. So why should I buy the expensive ones? So as a healthcare manager, you should be able to understand where the actual cost lies. The actual cost is not just in year zero. The actual cost is over the years. The actual cost is like how many things you need for that machine. For example, do you need consumables? For example, do you
Actually,
need training? For example, what is the annual cost? For example, what is the cost of upgrade? What is the total lifespan? All those things have to be fitted into the model, and that's why your results have to be analytical. And that's the difference between a healthcare manager who's trained and making these decisions about technology and a healthcare manager who's not trained. So just to give you an idea. Okay, this we have to move on because we are short of time. We have somewhere around like 1 hour 20 minutes left, but I know we don't want to go through the like the whole time. We want to like keep this as interesting as we possibly can. So again, let's start with okay, what are the core technologies and what are the key management challenges? Now, what we'll do is that we will walk through every department of the hospital, and then we will see what is the technology in every department of the hospital, and then we will look at what is the technology, what breaks in that technology, what is the cost, and what matters. And then after we are done with this, then we'll go towards newer technologies like AI, robotics, IoTs, Internet of Things, stuff like that. Okay. So within the radiology department, we have some like example of some technologies is the MRI, the CT scan, and the X-ray. So, what is the cool thing about these things? Like, what are the tech things in this? With MRI, we get superconducting magnets. We get high resolution image of soft tissue, which is not possible with any other technology to date, till date. Okay. Obviously, you can have now there are portable MRI as well that can be used. What are the management headaches? You need to refill the helium. You need to make sure that there is a safety pipeline that is there. You need to make sure that patients who are claustrophobic, you need to manage them. So you might need to sedate those patients. Similarly, you have to do strict metal screening. Or if someone has had, say, a metal implant somewhere, so that you need to be very, very stringent about that. For when it comes to CT scan, you can go for 3D print, 3D imaging. You can go for trauma workhorse. What that means is basically CT scan can be literally applied in any trauma situation, and that really gives you a good idea of what the patient has so that you can easily manage the patient, maybe take the patient to the operating room if needed, stuff like that. Similarly, or stop a bleeding, anything like that in the emergency room. The issues are radiation. The issues are you have to replace the tube, the X-ray tube in the CT scan, and then the CT tube in the CT scan, and then obviously there is a high power consumption, especially in low-income country, and that's like the reason why I started with know where you are in high income, mid income, low income. And then because that really defines the technology that you can use. Because in a high income country, not using a CT scan would be wrong. In a low income country, using a CT scan for everything would be wrong. So those are like some of the decisions you have to make. X-rays are fast, they're affordable, they're widely available. But again, you have to look at the safety compliance. You have to make sure that there is lead apron available. You have to make sure that For example, you have an old machine which is analog, and then you have a new machine which is digital. Obviously digital is also not very new now. Digital is like 20, 30 years old. But let's apply AI into this. What if you have the x-ray machine with AI compared to a x-ray machine, a PACS system which has no AI? The PACS system with AI would definitely like reduce the cost. Why? How will it reduce the cost? Even though you will be hiring radiologists, but the thing will be that with use of AI, your time of reporting will go down dramatically. So your radiologist will then just be someone who checks up on the machine rather than the one who writes the whole machine down. Similarly, if you like deploy a transcription machine, so you can just type the whole report down rather than write it down. So those are some of the solutions that are there. What are the key questions? The key questions as a manager, you need to think about how will you track the radiation? What is the backup plan if the CT scan fail? CT tube is like fundamental. So if you have say one hospital and the hospital has say one CT and MRI, then you have to think about what happens if it fails. Also, if the PACS integration functioning properly, then that's great. But then, say there is a new technology like AI deployment within the PAC system, then can you deploy new AI into your existing packs? Because that would be like lower cost. So, or do you have to deploy, say, no, like a separate packs unit for your AI? So then that's like very high individual initial procurement cost. So those are some of the things you have to think about. If you are in the ICU, and if you're managing the ICU, then you have to think about, okay, I have ventilators. So the cool thing about the ventilator is that basically it helps the patient breathe who cannot breathe. But the thing is that you have limited amount of ventilators, and then you don't have a lot of backups available, especially when you're dealing with a tertiary care facility that is already overwhelmed in a city like Karachi. Also, there are like other supply things like what is the situation of oxygen supply. What happened in COVID was in COVID-19 there was a big issue of oxygen supply. So oxygen cylinders were not available. Similarly, some things might happen that maybe there is a breakdown of equipment. Then what will you do in that case? Also, like for example, you need human resource to run your ventilators. What if you can deploy new tech like AI? So then your average nurse can run your ventilator. If that is the case, then that basically means that you don't have to invest. You rather than getting like say 10 ventilator technicians for ICU, you will now have to get maybe one technician, and then you will have nine normal nurses, and they will be supported with a AI tech. So, like those things are there. Those kind of things are being applied across the world, and that's why what I'm trying to tell you guys. Every time that you hear the term "no, the AI will never replace us," well, it's already replacing you. And there was I just went into a conference like last week. It was an AI conference in Saudi Arabia, and there like the guy who was the speaker, he was the previous head of NHS, National Health Services in the UK, and he said something. He said, "Okay, fine. When doctors come to me and say, the AI will never replace me, I tell them, well, if the AI does not replace you, a doctor that is using an AI will definitely replace you." So, similarly, a nurse or an ICU technician that was very valuable for us because he was the only one who could run the ventilator might not be that valuable for us because now I can make a normal nurse do that work. So that changes the whole leverage. Now that previously, if the ICU staff went on a strike, if I was the ICU manager, I would go like nuts. I would go crazy. I'd be like, how do I manage this now? But now, if I have the right technology, they lose the leverage. So, and those are the questions that come up again and again. Similarly, from a hospital perspective, you have a patient monitor in the ICU, It takes care of your heart rate, it takes care of your blood pressure, it takes care of your partial pressure of oxygen. Now imagine the cost of this patient monitor goes down very rapidly, which it already has in the past 10 years. At the same time, what happens is that it's also coming up with an AI decision support system. So basically, your patient monitor is basically a doctor now, because it's taking all the data of the patient from the EMR, electronic medical record, and then at the same time, it also has the sensor data. So it has the sensor data, it has the EMR data, it also has an AI decision support system. So then, say you have a shortage of doctors, or you don't have doctors that are like trained properly, or maybe you can't even afford a doctor, you just have a nurse on call at, like, say at night. Well, no problem. So that's the cool part of it. And so you can easily do EMR. And what if you have like three facilities? So you don't need like that many human resource. So like one facility can be run by one person, or maybe the three facilities can be run by just one doctor. I'm talking about like a PHC facility. And you can deploy that at the level of the PHC. And you can literally have daycare in the PHC. You can increase your patient supply, and you can like market yourself. We are the PHC that provides daycare services and round the clock patient monitoring at the primary care level. And yet your human resource cost, the biggest cost in healthcare is human resource, full stop. You can look up, there are so many studies done on this. And so like I'm not someone who's advocating that we need to replace the human resource. But like I said, like I was talking to one of the breakout rooms, health is not a health issue, it's an economic issue. Human resource is not a resource issue, it's an economic issue. Education is not an educational issue, it's an economic issue. Politics is not a political issue, it's an economic issue. And then you can go on and on and on, right? So hospital administration is not an administration issue, it's an economic issue. Everything boils down to economics. Therefore, even though I'm talking about technology, but one of you in the group said, this looks more like health economics. Well, everything is economics. So just to this is why I'm trying to like open up your eyes towards this. Similarly, battery backup. There is huge revolution that is happening in battery backup. Okay. So, say right now, if you're deploying a patient monitor and you're deploying that patient monitor in a hospital, and then your hospital administration might say, that would be a lot of electricity cost. Well, what if we can deploy a battery that is powered by solar? So I get a few solar panels and I put up a battery, and now basically I'm independent of the grid. And basically, I have 24 hours backup power generated system in a PHC. I'm not even talking about the hospital. That's like the future of healthcare. Do you think it is happening? Yes, it's happening across Africa. There is a revolution that is happening. Like drone technology is imagine autonomous drones delivering pharma care, delivering organs, delivering blood supplies from the blood bank to rural area when there is no road. There is no road, and yet you're getting that faster than you'd get it if you had an ambulance. So, like, those are the things that are happening. So, and obviously, like there are ups and then there are downs. So with a human, you don't have to worry about the calibration. But with a machine, calibrations can go wrong. So you have to be very, very, that's why you need humans. That's why you would have humans within the hospital, but the current work that they're doing, that would change. That would change dramatically. And like I said, I told you guys, we are at 50% right now. 80% of the time is done. The next 20% of the time will go very fast. So, like if it took AI 15 years to get here, the next thing will happen in 7 years. So, like just to give you, or maybe less than that, 5 years. So, with that being said, what if you have infusion pumps in your ICU, right? So, precise medication delivery. What if we can automate the whole process? Also, there is one thing that because I have been working with, we have literally created free masters of artificial intelligence, free masters in medical robotics. I'll share the links with all of you in the Zoom meeting at the end of the class. What I wanted to tell you guys is, mm, everything in the hospital is a process. Okay, you must remember, everything is what? Everything is a process. When the patient comes into the hospital till the patient discharges, think of it like this, like it's a factory line. Okay, I know it's a crude term to say it, but if this is the patient, okay, the patient comes in and this is the factory line. Herein comes in a patient that is sick, and here it goes out a happy patient. Okay, so a sick patient comes in, a happy patient goes out. Okay, in this middle there is an arrow. Arrow means there is a process, right? Everything in healthcare, from health education to health service delivery to healthcare management to procurement to supply chain, to every building block of health system is a process, and every process can be automated. Full stop. Every process can be automated. Um, and the surgical care, the process of doing the surgery itself is a process. Uh, so yeah, so I don't want to be like the scarecrow here, but this is a tech session, so I think I can speak openly. If this was a doctor's conference, I would be like, no, you guys will stay here forever. So okay. So with that being said, what if you are in the surgical suit, and in your surgical suit, and we use things like diathermy. Okay, diathermy is used to basically cautery, doing cauterization, doing putting cuts. Okay, reducing the bleeds. So diathermy works like this. I'm pretty sure all of you know, but just for the sake of this lecture, it's like a knife that has like electrical cauterization built into it. So it basically cuts using electrical impulse. It basically burns your flesh as it cuts you so that it stops the bleeding. There are issues. So you have to think about the burns. You have to also have a grounding pad placement so that no one gets electrocuted. At the same time, there could be other devices that could interfere with this. So, but then newer technologies are coming in that can replace diathermy, and that can be deployed in the hospital. You guys can look it up. There is amazing work happening. Also, I am an academic, so let me tell you guys, the top 10 universities in the world right now, eight of them now are in China, according to the latest estimate. There is only one American university left in the top 10, which is Harvard, and there is one which is from UK, which is Oxford. That's it. Eight of them are now in China. And within China, what is happening is there is a huge growth in the startup sector. Within the startup sector, the biggest growth is now being seen in the biomedical startups. Like they have found the treatment for diabetes. It is now FDA approved treatment of diabetes. I'm not saying management of diabetes, I'm saying treatment of diabetes. And there are numerous solutions that are coming up which will replace diathermy very soon in coming years. Because if you can do the cauterization without the burning, without the electrical part, and you actually don't need any power for it, then that's all good. And numerous technologies are coming in. Similarly, let's talk about laparoscopy. Okay, laparoscopy is minimally invasive surgery. That's the great part of it. Rapid healing, and you don't get those surgical scars that people hate. The issues: sterilization. The issues: camera calibration, because the doctor is using laparoscopy. Now, obviously, laparoscopic surgery will be replaced sooner or later by robotic surgery, laparoscopic robotic surgery. And eventually, it will be like, rather than minimally invasive surgery, it would literally be like nano robotic surgery. So, nano robotic surgery is a term, because I was there in this global health exhibition in Riyadh just like in October. So, there is something called as the nano robotics. There are numerous companies that are working on it. so that they don't even require that smaller incisions of the laparoscopic. But obviously, there is a long way to go in this. And imagine if these nano robots were autonomous, because it's a process that they have to follow. They will follow the process, and they will have fail-safe and redundancies built into it. You remember the first thing that we said? So what if the ICU goes wrong? How do you save it? Redundancy. So what if any technology goes wrong? Redundancy, 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 redundancy. What is redundancy? Well, keep an extra pair. That's in simple terms. Keep an extra thing. Okay, that also robotic systems. I'll tell you what, in the year 2000, there was only one robotic system in the world that was like widely accepted, which was basically Da Vinci. Da Vinci is actually in SIUT, and I think I don't know if it is in AQ or not, but the Da Vinci is in SIUT right now in Karachi. Da Vinci can operate somewhere around 150 plus different types of surgeries. Okay. Now, Da Vinci was built by an American company, and the American company, like all American things, is expensive. Like American cars are expensive, right? So, what Da Vinci did was, Da Vinci is like, if you have to get Da Vinci, you need to have like a whole infrastructure replacement. The whole OR has to be built around Da Vinci. Well, what happened was that the IP, intellectual property of Da Vinci, expired in somewhere around 2015, 2016, 2017, something like that. And low cost companies across Europe and now across China, what they did was they said, what if we don't we build Da Vinci but low cost? And what if we build it like the company that builds Da Vinci is Intuitive Surgical. The name of the company is Intuitive Surgical. So what if we build a robot that's like a vacuum cleaner, and the size of a vacuum cleaner, and then like a robotic arm comes out of it, and it does the thing, right? So it sounds sci-fi, it sounds fiction, but I have actually now seen. So like what they did was they said, well, why do we need a table? We need a table because the table was the requirement of the surgeon. But our robot does not require a table because it does not get any back pain and it does not need to stand on its two legs. So they said, what if we can like do it on the floor? We can do the surgery on the floor, like create an environment and do it. And what if we don't even need like a whole room, because the room is the requirement of the, again, because you dealing with human resource. What if I replace the human resource, and what I get is basically all I need is a plastic sort of tube, and I put the patient in the plastic tube, and the plastic tube is sterilized, and within the plastic tube the surgical arms work. So I actually don't need the whole surgical room. So then, you understand what is happening here? Forget about the surgeon, the surgical room itself loses its importance. The surgical table looks like a relic of the past. Like these are just the thought processes that are happening within these companies. And then you can think about, okay, if I can do all this, then I can do the surgery in a very sterilized fashion, and I can do that surgery in a primary care setting. No, if I can do that, well, if I can do it in a primary care setting, can I do that surgery, say, in the patient's home? So the patient never leaves the hospital. Why should I expose the patient to nosocomial infections, the infections that happen between 24 to 48 hours after a patient comes into the hospital? So why should I do that? Why should I do that to my patient? So you see how the system is thinking, and at the back of this is economics. What is the surgeon is too costly. Simple as that. So like solutions are there. So like I hope I'm not raising alarms, and I hope in the Q&A you guys don't kill me, but this is what it is. Okay. So that brings us to laboratory. Okay. We in the laboratory, there is now imagine like a container. Imagine there is a container like a truck, like a vehicle. You see like lorries, containers on a lorry, on a truck. So like that container basically has the whole laboratory built into it, and the whole lab is autonomous from get go. And so is that being done? Yes, it's being done. Has that been built? Yes. And the cost of that is lower than like the current laboratory setups. And all you have to do is that you have to fix the reagents, you have to like take care of the rental contracts, and you have to make sure that there is no quality check failure. You have to make sure that the labs are calibrated, like the equipment is calibrated. This you have to do with any lab. But then with the autonomous lab, that just reduces the cost dramatically. You don't have to hire a pathologist because you have an AI algorithm that's doing that. Um, but that being said, in 2014, there was a paper by Harvard Business Review that said in like 4 years, all the radiologists will be replaced, right? That was in 2014. You know what happened after that? In 2024, the radiology residency in the US has increased. It has actually increased. But what has happened is that the 2014 radiologists were basically not using AI at all. But now AI becomes a big part of the PACS system. PACS is the system that the radiologists use. Okay. So, like I said, so you might say if a doctor says, I will never be replaced by AI algorithm. Yes, you might never be replaced by algorithm, but you will definitely be replaced by a doctor that who knows how to use AI, and that's the starting point of it. And then obviously, through and through things will happen. Okay. Similarly, if you look at the biogas blood gas analyzer, like the ABGs that we do in the hospital, right? Arterial blood gases, like done in for every ICU, for every we need this, right? So there is a cost of the cartridge, there is a cost of expiration. Now already these things are disposable. The machines are very cheap, and you just get disposable cartridges, right? Imagine the IV cannulation becomes autonomous. It's already like you guys have seen those videos. Everyone has seen those videos. How long will it take for the IV being like the blood being taken from the IV of the patient, and like the machine that takes the blood, it basically does the ABG right in the needle. So that's the future, guys. Similarly, is the reagent rental cheaper than outright purchase? Those are some of the questions you need to ask. Again, when you're doing those purchases, you need to make those choices. As hospital administrators, you guys will not be expected to develop the technology. That's not the expectation. You guys are expected to implement the technology, and implement the technology in a cost effective manner, implement the technology in a way that is safe for the patients, implement the technology that is good for like the overall health system. Okay. So that brings us to the end of sort of the didactic part. We covered initially what was the like the what is the digital technology is like, what are the different classifications, and then we delved into like a case scenario where you guys thought about procuring a tech for your hospital. Then we delved into, okay, department wise, what is to be used where. Now we are like in the last hour of our sort of session. So before we go into any other thing, let's talk about like if you have any question and answer, and then we go to the next session, next thing, the next part of this workshop or session, whatever you want to call it. Okay. With that being said, so there is a crisis scenario. This is again we can even skip this part of the workshop, and we can dive right into like the tech part of it. If we get time, we will do this crisis simulation. Okay. Otherwise, basically, you would be given some tools, which will be your assets, and then you will be given some failure situations, which will be sort of your failure card, and then you will be running these 5 rounds: failure one, failure two, failure three, failure five, and then you would have these assets to use in this situation. So as a manager, you will be using them. We can run through it, but before we do that, I want to take you guys to something else. What are the disruptors? Let's look at the disruptors right now. Disruptor is what? Which basically comes into any industry, and then it changes the industry completely. Okay. So one of the big industries is artificial intelligence. But that's like, this is the famous, if they're like four brothers and one brother becomes famous, this is the famous brother of the technology suit. Okay. But there are other brothers that are also more famous. Let's see what they are. Within AI, we have data-driven algorithms for decision support system. This is just one example. For example, you have a CT scan. Okay. So right now you need a radiologist. Well, now the AI can just flag the brain bleed. It is happening now in every hospital around the world. The AI is helping the radiologist. Okay. Then from managerial impact, why is this important? Because, well, if you can check this brain bleeds, then what you can do is that you can send that person directly for the OR, and then that person can get a burr hole, and then you can relieve the pressure of the brain, something like that, right? So from a managerial perspective, you can easily shift the person from the ER into the hospital and rapidly get the treatment done, and then the person can be rapidly taken out from the hospital, means that the turnaround time of the ER and then the turnaround time of the hospital becomes very good. Similarly, this reduces the burnout. Why? Because the radiologist doesn't have to work so hard now. There is a tech that is supporting it. Like similarly, when I was building this presentation, I took help from ChatGPT. So it made my life easy. So if you're writing a research paper, you take help from, say, there are numerous tools out there that are well, like apart from generative AI, there are tools that you can easily use, and existing tools now are using AI within healthcare research. So that's there. So the key question is, when we do this, do we have regulatory approval? And a good thing is that the same people who basically approve the drugs, the FDA, these are the same people who approve technologies. So FDA approves technology as well. So FDA approval can be taken for any AI algorithm. The process is the same. You have to go through a clinical trial. You go through a clinical trial process, phase 0, phase 1, phase 2, phase 3, phase 4, and then post-market survey. Post-market survey is the phase 4. So is the same process. You go through a trial phase. Similarly, in PACS integration means once we know that the AI works, we can integrate it into any PACS, into any radiology system, and so on and so forth. And then would be the cost. The good thing is that what Microsoft did was Microsoft made everything like you had to buy the Office, Microsoft Word, Microsoft Excel, stuff like that, right? So Google created something called as Google Sheet, Google Word, stuff like that. And they disrupted the market of Microsoft so much so that Microsoft allowed people who did not even have the key to use the Microsoft Office online for free. Okay. So same thing happened was that we had these generative AI solutions coming from the US capitalist market, like ChatGPT and Gemini and BART and this XAI, right? So then what the Chinese did was that they made it open source. So it started with DeepSeek, then Kimi, then Quen, and then now basically most of the AI solutions that are being deployed by American startups at the back end of it is a open source AI algorithm that is Chinese. So that's like happening across the board in AI industry. So you can rapidly reduce the cost of AI development and deployment by using open source cheaper AI algorithms. What is the cost of it? Like as a doctor, you can do that in your hospital. You can literally automate the whole hospital. The cost of that is somewhere around $6,000. Pakistani, matlab 18 lakh rupees, something like that. So it's not very expensive. Hospitals pay way more than that. A PHC can easily afford the 18 lakh rupees. Similarly, Internet of Medical Things. So there was something called as IoT, Internet of Things. Now we are seeing the rise of Internet of Medical Things. So what is that? Smart devices. Like for example, the bed is smart. So when the patient lies on the bed does the has sensor. It takes care of the blood pressure. It calculates the heart rate. It calculates the temperature. It calculates like it can through hypodermic needle. It can easily take samples of your blood sugar. It can take samples of say your like ABGs, your other profiles, your lipid profile, your LFTs. At the same time, it can even give drugs via hypodermic needles. And hypodermic needles are basically like a patch. You would feel like you're put in a patch, and then that's the whole drug. So smart beds in the hospital are there. They are very important for people who are paraplegic or hemiplegic, especially stroke patients. And they literally rotate the patient regularly so that the patient does not get a bed sore. Stuff like that is now common. Okay, and it's now rapidly coming into low income countries as well, because it's very low cost now compared to what it was like 10 years ago or 20 years ago. And obviously, if you can do all that, then why would you need a caretaker? So a caretaker, people used to hire a caretaker. Like caretaker is someone, you can say, like not a nurse, but someone who just takes care of a stroke patient. Like for example, if an elderly patient in the hospital, in the home is sick, then you would hire someone to do that work. Well, now you have these smart beds, and smart beds are the starting point of it. Then sooner or later you will have humanoid robots, and then humanoid robots would basically be sort of like a care companion, a care companion that basically feeds the patient, that makes sure that the patient. A big problem why people would keep the caretaker was that they were afraid that their elderly parent would choke, because in a stroke patients that's like a big thing. So they were like, "Look, who will take care of their respiratory hygiene, who will take care of them, make sure that they are like well. So, well, now you have amazing camera technology supported by AI, and at the same time, you have these smart beds. And this is the starting point. Sooner or later, you will have humanoid robots that will basically be doing the whole thing in the form of a humanoid robots. And the cost of that is going to be somewhere around $20,000, roughly Pakistani 60 lakh rupees. And this is like the starting cost. And it will easily come down to like 3,000 dollars, which would be somewhere around like 9 lakh Pakistani rupees. Somewhere along those lines, for 10 lakh, you can get a robot. So, if you get like a caretaker for a month, that's like the cost of that 24-hour caretaker is like 150,000 Pakistani rupees. So that's like 9 months. And the stroke patient will be needing that care for like 10 years. Because I used to run a startup that would provide caretaker services to people in Karachi. It was called Health Rever, backed up by an app. So we now know that this is the future. And so rather than tapping into building, like focusing on training people to become caretakers, we should focus on building low tech robotics. That's where the future lies. This is just to give you guys an example of what is happening out there. So this is the Internet of Things, IoT. For example, IoT can be, for example, there's an old person in the house, right? And your house has stairs. So you can easily apply IoT to your stairs. Easily, you can build like safeguard rails that don't allow the person to fall as they're coming down the staircase. So stuff like that, real time tracking, RPM revenue. So, furthermore, this one key thing, one key consideration that people get all the time now is, okay, who owns the data? This is like a big thing. Initially, the thing was that every time you would ask someone this, and there are so many now, people who are working in this area, ethics of data, right? So initially, the conversation was that, okay, so if you have like a technology, who owns the data? Everyone said, well, the patient owns the data. But then when the hospitals realized that there was so much money in the data part, so they said, well, what if we basically have ownership of the data? So when now if you go to a hospital and you sign that I'm going to get treatment, so you sign a consent form. In the consent form, there is a clause which the patient never reads, that we will use your data for scientific research, and we will use your data for development of technologies. Now that could mean anything. Scientific research, like every startup that I have built, at the core of it was scientific research. So there is like very cloudy surface, so you can easily like hop on from a science to the startup, to the startup to the company, from the company to a $1 billion empire. You can easily take that jump. So those things are there. So initially the conversation the hospitals and the doctors used to say, Well, the ownership of the data is with the patient. Then it shifted to no, no, the ownership of the patient, the data lies with the hospital and the healthcare facility. Now there is again a pivot. Now they say, no, no, it lies with the platform. So you guys understand at the back of it is, who can use the data. So that's changing, that's happening. And then there is network security. That's a big thing. Cybersecurity is a big thing. If I can get anyone's data, if I can release that data, if I have access to their data, I can even attack them. I can use that data to even, like, for example, if there is an important person, like a political person, I can use their healthcare data. So all those things are there. So, similarly, robotics and automation. I talked briefly about robotics. When people think about robotics, they go straight to surgery. But I'm telling you, uh, surgery is like, again, like it's the brother that got famous. Robotics is already in pharma, already there. No one sees it. In the drug development, it is there. In the drug supply chain, it is there. In the logistics, it is there. It's already there. Now robotics will be used for disinfection. Why do I need a housekeeping human resource? If I can have a robotic vacuum cleaner in my home, why can't I have a robotic vacuum cleaner and not just a robotic antiseptic, a sterile, something like that, robotic cleaner? Why can't I have it in my ICU? Why can't I have the cleaner three-dimensional? It even cleans the walls, not just the floors. So yeah, so that's like where we are going. Surgery will definitely be famous because why? Because the surgeons were the most expensive thing, and the thing about economics is that you first try to mitigate the most loss. So the biggest loss for the hospital was the surgeon. So the mitigation of that risk, you try to mitigate the risk, is that you deploy all the efforts to mitigate the biggest risk. But on the sides, so many things are happening. You will definitely have automation of nursing care in the next 7 years. You will have that, at least in high income countries, and then so on and so forth. Uh, all of this will require a lot of energy, and a lot of that energy will come from solar energy, and a lot of that storage will come from battery technology. Okay. Key questions. What is the ROI? We don't build technology just for the sake of building technology. As a hospitalist, as a physician, as a hospital manager, you guys know that. We build this for ROI. How much money can we save for the hospital? How much improvement can we do in the health outcome? And obviously, the service model. Do you guys know that 1,000 years ago, there were no hospitals? Everyone used to get home health care. When did the hospitals come? The hospitals came with the Industrial Revolution. Why did the hospitals come? Well, because people started working in industries and factories. Because they were working so close by, they ended up having infections and dying. So that was a problem for the industries because the industries needed healthy workers. Healthy worker is equals to more profit. So what they did was they said, well, we need a solution. So they said, like a factory, we will build a medical factory. The name of the medical factory was the hospital, the tertiary care facility. And within came the advances in public health, like people learned how what the importance of hygiene. And then came vaccines, and then came antibiotics, and then you understand where this is going. But then you must understand that the hospitals were a creation of the Industrial Revolution. The Industrial Revolution is now over. We are entering into the age of Information Revolution. In the Information Revolution, if the products will be built through 3D printing, then why do I need to send the patient to the hospital, through the industrial hospital? No, I can treat the patient in a home care setting. So, and the technology is becoming cheaper and cheaper. Every person can literally own their own ventilator. Every person can literally own their own robot. So, if that is the case, then what's the point of having such a big tertiary care hospital? So, you will see in the next 30 to 40 years that the hospitals of today will become dinosaurs. And, we have beautiful buildings called churches in around the world. but they are very beautiful. But the utility of those buildings is now less than 20%. Similarly, we have beautiful mosque in the Islamic world, right? The mosque in the Islamic world 1,000 years ago used to be where the Qazi would sit and give out his decision, used to be the education center. So they used to be the madrasa, the school. They used to be the place where people would get this justice. So they used to be the courtroom, and then also used to be a place of social gathering. Uh, Now the mosque is just a place of worship around the world, not with any country. So the utility of that has gone down, and if the utility goes down, the power and the leverage goes down. So if the utility of the hospital goes down, the power and the leverage of the hospital will also go down. Simple as that. So I hope this is helpful. There's a message in the. Yes, very nice. So but then they were someone is saying Kamran, Mr. Dr. Kamran is saying that the first hospital was built in Baghdad in 805 during the reign of the Caliph Harun Rashid. Very nice. But you must understand that the modern hospital with all its things, this is basically something that came with Industrial Revolution. Um, you guys can look it up. Okay, with that being said, I don't want to delve more into this. 3D printing. If you look at 3D printing, point of care, what is happening with 3D printing? Well, you are seeing prostheses being developed. Implants are now being 3D printed. Similarly, you are seeing prostheses being 3D printed. You are seeing even bandages now being 3D printed. You are seeing nanotechnology at work when it comes to burn patient care. So all of those things are happening. So regulatory clearance is there for some things, but it's coming in. And right now, insurance does not cover a lot of tech, but it will cover in coming years because they will become the mainstay products. Okay. Similarly, telemedicine. Telemedicine has been there for now like 30 years. In COVID, it became like the mainstay, right? And then the good thing about telemedicine is, like, I'll tell you what, a majority of the people in one way or another now use generative AI before they even use a doctor. And then majority of the people now prefer that if they can just talk to their doctor without going to the clinic. So that's another change that is happening. And now, say if there was a AI doctor, that would be even better. By the way, generative AI is basically an AI doctor. Without saying it, they have actually created an AI doctor. Um, Obviously, there are numerous issues with this, but there are issues with every new tech. So, in the interest of time, we have like half an hour left. We'll just do this last activity and then we will complete it. What you have to do is that you guys have 5 minutes. You guys are in the hospital board and you guys have been given 500,000 to bring an innovation into your hospital. Okay, $500,000. Pakistani, that would be 1 crore, and I think $100,000 is 3 crore. Sorry, so three fives are 15. 15 crore Pakistani rupees. You have been given 15 crore Pakistani rupees to bring in any innovation into your hospital. Okay, you have 5 minutes. All of you individually have to think about, even though this was a group activity, I think we can do this as a individual activity. You have 5 minutes to think about where will you invest this, and these are the considerations you need to keep. Your pitch has to have this: patient safety, revenue growth, cost saving, competitive advantage. I'm giving you 15 crore. 15 crore. And it's not a big amount for a hospital. Okay. And we want you to get us an innovation that is the best in patient safety, that will give us a huge jump in profits, so revenue growth, and that would do a lot of cost saving. That would save us money and give us competitive advantage. Okay, you guys have 5 minutes to think about it, and then one by one, all of you will have 1 minute to pitch it. You will have in these four areas what you choose and why you choose it. Okay, hospital anywhere where you are based, private or public, leave it up to you. It totally depends on you. You can deploy it in private, you can deploy it in public, you can deploy it in Pakistan, you can deploy it anywhere. Heck, you can even build a startup. You can go home health. Go all like, even though you guys are becoming hospital administrators. Oh, I'm sorry, this is a hospital administrators masters. I talked about the redundancy of hospitals. I'm really sorry. But you guys can even talk about like home health. The hospitals will not die, the hospitals will evolve. Sorry, I used the wrong terminologies in the wrong presentation. So you guys will all have your jobs. The hospital will evolve. As hospital administrators, if the hospital administrator thinks कि अगर उनको 15 crore मिले and he uses just 1 crore and sends back the 14 crore, and a lot of administrators think, oh, look, I'm so great, I saved a lot of money, I send back 14 crore. But the problem is that was developmental fund. That was not fund to be saved. So you could have used it for like things that could have helped the hospital 10 years down the line. That's why, as an administrator, as a
True.
manager, you have to be forward thinking and you have to be able to predict where you will invest this money. That's why we are having this conversation to and fro. And all of you are correct, none of you are wrong. But you must understand that like saying that you can only use 1 crore is not a good thing. It actually looks bad on the resume because you could have done thousands of things with this. Like, let's move to others and then we will. Okay, this is a thought exercise. Okay, so everything that you guys are saying is correct. My purpose here to is to push you over the cliff so that you are able to think beyond what is out there. That's why the competitive advantage thing is there to push you. Okay, think about what is not there in the market right now. Okay, I hope this was helpful. I hope everyone mm, the previously basically I had created sessions like these, but they were for like general either public health people or general doctors. But the good thing about this cohort is that this is a cohort of hospital administrators. So that's really good because when you're working in a specific area, it's very easy to identify specific problems and then to find specific solutions. And that's the beauty of specialization. So I think that was like for me, this was my learning experience. If there is anything that you guys can give input, like what more can we add into this, do let us know. We will add things in this lecture. Like the two assignments that were supposed to be done, this presentation I will share with Dr. Amara right after you guys. I will also share the PPT. You can use this presentation as well if you guys want to use it anywhere. I hope this is helpful. So, in the interest of time, we can, I think, conclude. Oh, yes, Dr. Zainab, you have a hand raised.
Sir, I have a question. Sir, I wanted to know what you would do for this, what you would answer जो आपने question हमारे से पूछा था. Like, what's
Like
your
I would bring the hospital out of the hospital. I would build an integrated system. If you ask me, like again, it's all every question was every answer that was given was correct. It is what I would do. Why? Because I believe that the hospital has been trapped in the hospital. So what I would do is that rather than like there is something called as a hub and spoke model. You guys can look it up. The hub and spoke model is
okay,
that we create a central hub and then that digital central hub is connected with multiple spokes. So I would prefer to create an integrated system with an EHR, with a interoperability within that. But what I would like to do is that I would like to have hands-on approach at the level of the patient at their home. So home care connected directly with a central hospital hub. So imagine the hospital giving specialized care at the level of the home. That would mean that my patient never leaves the home. That would also mean that my patient never goes to any other hospital. So that would also mean revenue growth for my, because
Yeah.
all of a sudden my I can basically I also kill the business of all the private practitioners and all the general practitioners, because here I am the amazing tertiary care hospital at their home. So always I would think about how do I kill my competitor. That's the game. So my competitor is who? My competitor is the PHC centers, the GPs, the general practitioners, the labs that are independently working other than me, the radiologies that are working independently around me. So I would like to capture their business, and I would like to like basically build an integrated system where I build an ecosystem where everyone has to go through me, and I bring the cost down so much that the competitors just cannot compete with me. That's how China became China. That's how you defeat the biggest economy in the world, which is US. So that's the game. So I would be a ruthless, robo-centric, tech-centric hospital administrator. That is what I would be. But at the core of it, I would increase patient safety by many folds. I would also reduce the burnout of the doctors. I would turn my doctors more into innovators rather than bureaucratic pen pushers or lab workers or surgical staffers. I would turn them more into innovators. I would not let go of the doctors, but I would turn them into innovators or implementers of the innovation that I can purchase from somewhere else. That's what I would do. Yeah.
Thank you for your answer, sir. This was like was very eye-opening for me at least.
Yeah, because I've been an
Thank you.
entrepreneur, and as an entrepreneur, you have to look at the cost. Everything is an
Yes,
economic
sir.
issue. Like you remember that part, so I hope this.
Ji, sir.
Thank you. Thank you. Also, before I end, let me just share a few links. Everyone can join these links. These are free links. I have also shared these with Dr. Amara. All of you can join these. Anyone can. We have created free masters program. These are no one gets a degree from our masters. They just get the skill level. So there is a whole masters on data science. Uh, Here you go, and there are multiple groups. So I think, wait, here you go. These are free academic resources that I have created with my startup. Multiple startups I have. So these are for anyone, absolutely free. Anyone can, here you go. Anyone can copy this, and I hope this is helpful. I hope all of you can like look at the lectures. Everything is on YouTube. Most of the all these are academic, and we have created a free healthcare. We have now created four journals actually. All of them are open source. All of them are in the process of getting indexation with Web of Science. So other than that, like these four masters, anyone can. If anyone wants to contribute for free, they can contribute. This is like self-help services we created for everyone around the world. Even though we started this from Pakistan, our biggest cohort is actually from Africa. The largest number of students are from Nigeria. Yeah, and we have like a big following in Bangladesh, and also anyone can just copy this message, keep it with you. It has a lot of links. Go. We have free research workshops as well. Python programming, R for data analysis, Python for data analysis, meta analysis, um, robotics. Okay. Why did we do this? We did this. I did this because so when the British came to the Mughal Empire, the person who came, Lord Clive, he gave Aurangzeb Alamgir a magnifying glass or maybe a telescope. And Aurangzeb was impressed. He's like, damn, this is like, okay, I can see this far. He said, yes, my lord, you can see the enemies coming from this far. And then that was just the starting point of it. And then eventually the British, or you can say the Western tech, just took over the whole world. And it is innovation that gives you superpower status. Now China is in the process of achieving that. My biggest fear is that my people will be left behind and we will be thrown under the bus again, like it happened in the previous industrial revolution. So we don't want that to happen. So what do? We create an army of data scientists, an army of health economists, an army of medical robotics experts, and an army of medical entrepreneurs. So in those four areas, we have created these free masters so that people from low income country and low middle income country can access these things for free. Obviously, we don't give any degree, but you get the whole skill set. You can even do a capstone project. So anyone can do this. Anyone can contribute in this, by the way. We have contributors from all over the world in this, from students to professors. So thank you so much. I hope this is helpful.